to record this talk. Oh, there she is. Okay. Hi, Shannon. Welcome, welcome. Yeah. And as I was saying, just thank everyone for joining us today. If you can, we would really love to see your faces. And I'm actually going to introduce our student leader, Jeremy Amard, and he's going to lead us in an opening prayer. Jeremy?
Sure. Hey, everyone. Okay, I'm going to pray us in. Father God, we thank you so much for this day and the chance to hear from Shannon and how you are working through her and you have been. And I pray that you just speak through her today and just teach us how to be your hands and feet, Lord, in this dark time, and fill us with your Holy Spirit. And we thank you so much for all the blessings you give us. And thank you for Jesus. In his name we pray. Amen.
Amen. Hey, thanks, Jeremy. Hey, again, I just want to say thank you, a big thank you to Shannon for being willing to share today with us. Yeah, I just cannot believe that I actually met Shannon when she was a student at Baylor in Houston just a few years ago. And now she's a full-fledged PA and serving all over the world. So very proud of her, thankful for her, and yeah, and I'll let her share now. Shannon?
Hey guys, well, thank you so much for letting me join you today and share with you. So I do have a little presentation with some pictures and slides and stuff, but this is super informal. I just want to kind of share with you guys some stories about my experiences and what God's let me be a part of. So feel free. I'll leave some time for questions at the end, but if there's anything in the middle, if you have any questions or anything, I like discussions, so feel free to jump in. But yeah, so like Stan said, I'm a PA, so my guess normal job is I work in the ER, and I've done that for about 10 years. But my favorite job is doing admissions and disaster relief work. So God has just really blessed me and opening up some just really incredible doors and opportunities in the last couple of years that I certainly don't deserve. And so I just want to share with you guys how God has used me and how the things he's let me be a part of, and how you can be a part of those things too, because I promise you there's nothing special about me. It's all just Jesus opening doors. And I know, when I was much younger and started feeling called to missions, I know one of my original thoughts was always like, well, that's those special Christians. Like, there's Christians who are missionaries, and then there's the rest of us. And of course, what God showed me over time is that's all of us. It's really not about us. It's about him. And so if you have faith in Christ, that's the only qualification. And so I'll go ahead and pull up my slides here and screen share. Hopefully, I've never tried this before, so, and get going. Okay, sorry guys, just a second. It's making me fix some settings. Sorry. Okay. I think I got this. All right, can you guys see my screen? Yeah, awesome. Okay. All right, so I have a lot, so I'm gonna go quick. So what I'm just gonna talk to you guys about today mainly is my experiences with Samaritan's Purse, working as part of their disaster assistance relief team, or DART, and that's gonna be Ebola and COVID. Starting out, I just wanted to share with you guys this really awesome quote from Kent Brantley, who was, of course, the Ebola survivor from the 2014 West Africa outbreak. So what he said was, "I learned so much. There's so much more to being in a position than curing. Than curing illness. It's not the most important thing we do. The most important thing we do is entering the suffering of others." And so just keeping that in mind as we go through, right, that's really what our medical careers are all about. And that's what I just want to focus on, is how being healthcare professionals opens that door for us to so uniquely enter the suffering of others. All right, so real quick intro, why does global health and humanitarian medicine even matter? And so I could give you 1,000 reasons, but just a few of the big ones. Why is it so important that we as healthcare professionals jump into these issues? And it's because there's so much incredible need. So just a few of the things that have happened in just the last couple of decades, right? So there's armed conflicts that create all kinds of medical need. In the Rwanda conflict, there were yes, a lot of people that died from violence, but there were actually 50,000 people that died from cholera. So the medical crisis was just as much as the crisis of the violence. With refugee crisis, there's about 42 million people displaced currently, and most of those people have little to no access to healthcare, as well as being in very difficult situations that create a lot of healthcare crisis. Just in the last 20 years, we've had multiple natural disasters, and it created huge need for that humanitarian medicine, disaster medicine. So we had the 2004 tsunami, killed 230,000 people. I'm sure you all remember the 2010 Haiti earthquake. All kinds of ongoing disaster response and medical response that was required there. Then we have disease epidemics, which we're all very familiar with now. So we had the West Africa Ebola crisis. There were 28,000 suspected Ebola cases and over 11,000 deaths related to that outbreak. I'm, of course, going to talk about the outbreak in the Democratic Republic of Congo. And then I'm sure you've all heard of something called COVID-19. So far, as of today, according to Johns Hopkins, there's 4,700,000 cases worldwide. We have famine, malnutrition, and then, of course, if you've ever heard of the neglected tropical diseases, so these are diseases that are big problems worldwide, but essentially undertreated because they only happen in developing countries where there's not a lot of money in pursuing pharmaceuticals and treatment for them. And then, so we have all these situations that create the need for healthcare, and then ultimately healthcare really, access just really doesn't exist in a lot of areas of the world. So two areas that I work in a lot and I'm very familiar with are India and Liberia. So in India, per 10,000 people, there's 6.5 physicians. So think about that, six and a half of us trying to treat 10,000 people. 9 nursing and midwifery personnel, again, per 10,000 people, and 0.8 dentists. So, right, so essentially dental care, for instance, just doesn't exist. In the entire country of Liberia, there's 51 Liberian doctors, right, for the whole country, 51. Now there's other doctors, but as far as like Liberian doctors, there's 51, and there's almost no specialty services available. So that comes out to 1 doctor per 75,000 people. And so it's easy to see why it's so important that we get involved and that we do something. So with that kind of background about why this all matters, I'm just going to kind of jump in and share with you guys a little bit about my experiences with the Ebola outbreak. Obviously, this is more of a, informal things. I'm just going to share with you guys more about the personal experiences versus the scientific or kind of technical aspects of all of that. So Democratic Republic of Congo, it's actually a pretty large country. landlocked in Central Africa. Like many of these countries, very war-torn, lots of armed conflict, lots of insurgent groups that create a lot of instability, governmental issues, so poor infrastructure, poor healthcare infrastructure. So when something like Ebola happens, it's really hard to create an appropriate response. So the Ebola outbreak in DRC was actually declared August 1st, 2018, and it's still ongoing. So back in March, they had reached 0 cases, and we're hoping that the outbreak would be ended. Ebola has up to a 21-day incubation period. So for an outbreak to be considered cleared from an area, you have to go 2 incubation periods, essentially without a case, so 42 days. So on day 42, they had a new outbreak of cases back, like I said, back in March. And so they've had a new ring of cases. It's a very small ring, so hopefully they can get that shut down. But there's lots of reasons it's really, really hard to end an Ebola outbreak. And one of those, what happened both in West Africa and possibly what has happened now in the Congo, is that the Ebola virus can continue to be transmitted through semen from a man for months. They're not entirely sure how long, but probably a good 6 months. And so there will be outbreaks related to sexual transmission up to several months later. So far, there have been over 3,200 cases and 2,100 deaths. So that's a case fatality rate of 65%. So think of that, 65% of people that get this disease have died. And again, it's just complicated by areas of armed conflict and violence. So like the area that's the holdout now that they're kind of having trouble getting rid of, it's a very unstable area. They've had to pull out the response teams multiple times due to violence and community resistance. And so that just really is a huge complication on being able to address it. So just a little background about Ebola to kind of help understand what it's like to work in an Ebola treatment center. So Ebola is a viral hemorrhagic fever that is, I'm sure you realize, highly, highly contagious. So the difficulty about Ebola is that it's in all body fluids, so it can be transmitted through saliva, sweat, urine, blood, vomit, diarrhea, all of those things. And the sicker you are, the more full of virus all your body fluids are. So like by the time someone is dying, even, they're sweating, they're feverish, they're sick. So even that sweat, just all their body surface is essentially covered in virus. So then their family members care for them. In these communities in Africa, it's typically a really huge cultural tradition about caring for the body. The family, the close friends, they'll all gather around, they'll clean the body, they'll keep it in the home for a few days. And so you can see how it'd be very quick and easy for Ebola to spread to the family members and friends in the middle of all this. And that's one of the things that was really, really difficult and heartbreaking with the Ebola cases, is typically they weren't the first family member or the last family member. In fact, the last weeks I was there, almost every Ebola case we had in the unit was a familiar relation to each other. And so you're just watching family members die one after the other. Because it's so virulent and so transmissible, Ebola can survive on surfaces for several days. So you have to get teams in to clean the houses, to take out, the sheets and the blankets and dispose of them properly. All of these things. It can survive on surfaces. It's very, very virulent. So it takes a very small amount of viral particles to make you sick, right? So because of these things, you think of an Ebola treatment center as functioning to treat people with Ebola, but actually the most important function is getting people out of the community, right? So that they can be cared for safely and properly without spreading it to others. And so one of the things that this causes that, I would have never thought about until I had done this, is that you have to bring people in as soon as they have any symptoms of Ebola, right? So it's not like they're getting tested and staying at home or staying at the local hospital and then coming when they're positive. You have to pull them out of the community and get them into the Ebola treatment center right away, because if they have Ebola, they're incredibly contagious. And so it's that community good viewpoint versus the individual. And so what that means is a lot of times you're bringing people to the Ebola treatment center because they meet case definition, but they don't actually have Ebola. And you're very limited in how you can treat people medically at the treatment center. And so people may have other diseases that need surgical intervention, blood transfusions, other things that you can't offer them. And it was something that I really hadn't considered, is the way Ebola hurts and honestly kills other members of the community who have other diseases, because instead of being able to go to the hospital and get the treatments that they really need, they have to be brought to the Ebola treatment center and kept there as a suspect until they have 2 tests negative 48 hours apart. And so that was one of the really just interesting dynamics that I, would have never thought of about Ebola, is how it's hurting the rest of the community and hurting people with other illnesses. So a few things about working in an Ebola center. Obviously you have to wear the PPE, right? So I got some pictures up there for you guys of what those suits look like and what that's like. So as you can imagine, that complicates care a lot. So you have to go in teams of 2, but you can only go in teams of 2 because you have to save, you can only go in for a short period of time. So you have to save the rest of your team to be able to go in later. So that means there's not always someone inside with the patients because you can't stay in for more than an hour and a half, 2 hours. You're losing 1 to 2 liters of fluid and sweat an hour inside there. And so after about an hour, hour and a half, you're pretty wiped. 2 hours is absolute max that you could really safely be inside the PPE and inside the unit. So things like children, like I have a picture there of a worker carrying in a 3-year-old child. Well, you have to separate that child from their parents because if the child has Ebola, they're going to spread it to their parents. So then the rest of the family is getting sick. And now who's going to take care of all the other children and the rest of the family? So you have to separate them from their parents and bring them into the center. And then you have to leave them inside, right? So you have small children and there's essentially no one to take care of them. So one of the things we do is hire survivors because the survivors are immune. They don't have to wear the full set of PPE, so they can stay inside for several hours or even an entire 12-hour shift and help take care of the really sick people and the children that can't care for themselves. And then the other thing we did is we had the very front row of patient rooms that was like right across the fence was where we would keep the children who were there without parents. So that way, even when there wasn't someone inside, we could talk to the kids across the fence. We could, honestly, like throw things into them, snacks or toys, or just help them, understand like, hey, you need to stay in your room. And it was really amazing how well the kids would handle that and how well they would respond to that. Really, really quite impressive. We had a 2-year-old kid who would just sit in his room the whole time by himself, open door. And he would just sit there and you could just talk to him across the fence and he'd be totally fine and happy. So it's just really amazing seeing how resilient those kids were and how resilient people were in that situation. That top picture on the right hand side there is one of my favorites. In that picture, we're getting ready to go inside. So that's the donning area where you put on your PPE. And one of the really hard things about working at the Ebola Treatment Center is that so you're living there and there's a separate like living area for us on the compound. You're working there, you're there 24 hours a day, and you don't ever touch, right, while you're working there, because if anybody has Ebola, and the last thing you want to do is spread it to your coworkers and your teammates. And so there's no handshakes, no hugs, no high fives, nothing like that. And that creates a lot of, just a sense of isolation. You're working inside this PPE a lot. You're really separated from other people. But right before we went inside, when we first got donned into our PPE and we were all clean, we would always pray together before we went in. And you have that moment there where your hands are in clean gloves and you can grab each other's hands and you can pray together. And it was just such a special time of being able to join with each other in heart and in spirit and just go before God and pray for our safety and pray for our patients. And that's really one of my favorite pictures because those were always my favorite moments while I was there. And then the picture on the left, so I want to tell you about Mulasi. So Mulasi was our first Ebola patient, actually. So we built this center in an area that was supposed to be like kind of one of the epicenters of the outbreak. But then it turned out not to be for a couple months. So for a couple months, the team was there seeing patients, because you're bringing in suspect patients. Remember I talked about that, how the main thing is just get people out of the community immediately as soon as they have symptoms. So we're bringing in suspect patients, but everybody tested negative. So they hadn't had a single positive patient for a couple months. And so then Mulasi was actually our first positive patient, and that's when I was there working as the lead provider. So tips for if you do this type of worker disaster work, ask questions before you go, because I arrived and found out that I, as the PA, was the lead provider. I was the only provider there from Samaritan's Purse, and I was overseeing all the national physicians and all medical care that took place at the Ebola Treatment Center, which I didn't know until I got there. So, so I was there as the lead provider. We got our first Ebola patient. And her story was pretty heartbreaking. So she told us that her son had died 4 months ago of measles because she was so ashamed of what really happened. Ebola really comes with a lot of social stigma, right? When you have a disease that kills everyone around you if they get near you, and people have a lot of, cultural myths and misunderstandings about what Ebola is. So it creates a lot of social stigma, and people are really shunned from their communities if they do survive Ebola. And so she didn't want anyone to know that her son had Ebola. So her 4-year-old son had gotten Ebola from a friend that had died. So the friend had died, been tested, was positive for Ebola, and then her son got sick. But she was afraid he had Ebola and didn't want anybody to know that. So she refused to let the community health people test her son, and she ran away to another town and took him to a health facility there where he died. Lots of people were exposed. She, of course, was exposed while she was caring for him. She also refused to let the body be tested because, again, she didn't want anyone to know that her son had Ebola. And then she got sick, went to the hospital, got tested for Ebola, but got sent home for some reason we could never understand. So she exposed all the healthcare workers at the hospital who weren't wearing appropriate PPE, went home and was cared for by friends and family. Overall, with contact tracing, she'd exposed over 100 people to Ebola before she came to us, which is one, again, the really sad parts is when their healthcare system and their hospitals and their clinics don't have the appropriate education to identify and isolate these cases. Then what happens is it just spreads rampantly and quickly through the hospitals and through the community. So by the time she came to us, lots of other people have been exposed. Her son had died, but she didn't want anybody to know that her son had died of Ebola. So it took us a long time to track down that story because she wouldn't tell us. She was very, very sick right in the middle of it. So, Ebola starts out with just typical flu symptoms, fever, headache, body aches. Usually you develop some GI symptoms next, vomiting, diarrhea, stomach pain. And that's going to be maybe days 2 to 6, 2 to 7. And then around that first few days in, 5, 6, 7 is when people start really getting sick. And maybe you start developing more of the hemorrhagic symptoms, easy bruising, bleeding, more severe organ failure, septic shock, those things. And so she came to us kind of right in the middle of all that, really, really sick. And just both, just mentally, obviously with the death of her son, and then physically really sick. And I was there later when she got interviewed by a media team. And what she said was, I came feeling like I had no hope. And that's really where she was, and so thankfully we were able to use some of the experimental drugs. So there were 4 drugs, 1 antiviral, and 3 antibodies that were being tested. And so we were able to give her experimental drugs and treat her. And when I actually left from that first deployment and came home in April, she was doing really well, but hadn't tested negative yet. So you have to keep them at the Ebola Treatment Center until they test negative. So she hadn't tested negative yet, but was doing very well. And so I left her, confident that she would be okay, but not having seen her really, healed and negative and able to go home yet. And then when I came back in July, she was back at the Ebola Center working as a survivor. And it was amazing because the first time I saw her, I didn't even recognize her because she just looked so different, strong and healthy. And the way you see her in this picture, which is nothing like what she looked like when I was treating her for Ebola. And it was just really cool to see how, she came in saying, I had no hope, but these people cared for me and loved me, and I realized I could survive, and I realized God loved me. And she not only survived Ebola, but came back and went on to provide that love and that care to others. And in this picture here, she's actually taking care of a 10-day-old baby whose mother was a suspect Ebola patient. So the mother was inside the unit and had no one to care for the baby. And of course, you don't want to send the baby with the mother and expose the baby to Ebola. So she was caring for this 10-day-old baby as one of our workers in this picture. And it was just really awesome. So many times, and when we do, especially short-term mission work, you don't really get to see the fruit of that. You don't really get to see how it affects people. You don't really get to see how that work and that labor gets passed on to others. And so it was really such a blessing and such an amazing experience to get to come back and see her, see how well she was doing, and see her passing on that love and that care that we had given her, and passing that on to others. She actually got featured in an article about Ebola workers with Al Jazeera, which is where this picture came from, is from that media team. So it was really cool, just that I got to be a part of all of that with her and just see how God was using her. So that is kind of Ebola response in a nutshell. Before I move on, does anybody have any questions or anything about that?
You mentioned using survivors. Were there any other strategies you used to engage the community and enable them to be more sustainable after Samaritan's Purse left?
That's a great question. So Samaritan's Purse, and really, all, similar relief organizations, that's always going to be one of your biggest goals, is to, engage the community, be culturally relevant, but also to empower the community. And not create something that they're dependent on, but create something that's self-sustaining. So in this particular instance, and what's kind of a typical strategy, so we opened up the center, and initially it was staffed with all expat Samaritan's Purse workers. But then slowly over time, you hire local, national doctors, nurses, and then hand that over to them more and more. And so that's like, by the time I arrived, I was the only Samaritan's Purse provider. We had a couple nurses and myself that were kind of acting as, medical directors and charge nurses. But it was the local national medical staff that was actually doing the work and the care. Additionally, so kind of as I touched on, Ebola response creates a lot of community fear. For obvious reasons, a lot of community distrust. So, think about, you have these people show up in your community, build this giant fenced compound, wear yellow suits and masks, bring people in, and they die. And you don't understand why. Like, that's really suspicious, right? So one of the most important parts is engaging the community. So we hired local pastors and community leaders as kind of a psychosocial team. So they both worked with patients inside the unit, talked with patients' families, helped them understand what was going on, and also engaged the community with education and just opportunities to build those community relations. So one of the things that Samaritan's Purse does really well, they've been working in this area of the Congo for 20, 30 years. So they have really good community relations there, right? The community already knows and trusts Samaritan's Purse. So when we came in to build an Ebola treatment center, there was already a level of community trust. And then you put local, well-respected local leaders and pastors in place to go ahead to continue that community engagement. And so we were really blessed in being protected from a lot of that violence through that community engagement. Anybody else?
Did you ever have a time where you think you may have been exposed, and how did you handle that if that did happen?
So, you know, the thing about all of this, right, is it seems like Ebola seems so scary, right? And going in and all this PPE, or I mean, the same thing with COVID, right? Like, but as healthcare workers, as medical professionals, like this is what we know how to do, right? Like we know how to follow the science, we know how to follow protocols, and we know how to keep ourselves safe. And so, I mean, really, for me, it wasn't, it didn't feel that scary or frightening. You know, you learn the protocols, you practice before you're ever dealing with patients, putting on the PPE, taking off the PPE. And the protocols are extremely strict, you know, what you do, what you don't do. You know, like once you're inside, you never touch your face, you never adjust your PPE. If anything happens to anything, you know, you have a tear in your glove or your mask moves or whatever, you leave immediately. You do all of that with a partner. So the safety protocols are really strict, and I followed them, you know? So I never had any breaches in my PPE or anything like that. I never felt concerned about that. You know, you just follow it carefully, follow it safely. I will say, you know, like, so like the first week I was there, we didn't have any positive patients, right? So you still follow everything incredibly strictly because you know anybody could have Ebola at any time. And then when those like first Ebola patients started rolling in and realizing as you're like decontaminating your gear and taking it off, like I'm literally covered in a deadly virus. It's an odd feeling, I'll admit to that. But at no point did I feel concerned that I'd been exposed. No. Anybody else?
I was wondering how long it took you to prepare to actually go, like learning the protocols and maybe learning the language or how you communicated.
Yeah, we had a 3-day Ebola training where you learn about Ebola, caring for Ebola patients, and then do a lot of practicing, putting on and taking off the PPE, and then kind of a brief refresher when I got there. Language-wise, we had translators. So these are short-term deployments because most people, you know, are leaving another job or family, kids. So they're very short-term deployments. All right, well, I'm going to jump ahead because we are running out of time. So, all right, so COVID. All right, so what I just got back from is working at the field hospital in Central Park. So that was a joint partnership between Samaritan's Purse and the Mount Sinai Hospital System in New York. So at this point, New York has had over 200,000 cases of COVID and over 18,000 deaths. Those numbers are from a couple days ago, so they've probably gone up because it goes up quite a bit every day. I didn't look this morning. So New York, you know, initially it was North Italy, but New York literally very quickly became the absolute epicenter of the outbreak, and the hospital systems were just absolutely overwhelmed. And so you have to think about what it takes for New York City to invite a field hospital into Central Park, right? You know, things have to be pretty bad. We never thought we'd be doing a U.S. deployment, I don't think. It was a very different, very unique experience, very crazy, right? To be setting up tents in a field hospital in the middle of Manhattan. So I'll just share a little bit about that with you guys. Again, I'll kind of skip over some of the, you know, technical stuff. You guys know the situation with COVID and what it is and all of that. I'm sure it'd be hard to miss. But I'll share just kind of briefly about what we were doing. So we had a 68-bed respiratory care unit. Essentially, we had 3 general ward tents that were 14 beds each. People in there could be on oxygen up to 15 liters and a non-rebreather mask. We had a 12-bed step-down unit where we were able to, you know, put people on non-rebreathers and CPAP. So we didn't do BiPAP because BiPAP aerosolizes the virus really bad, and you have to have negative pressure. And our step-down unit wasn't negative pressure. CPAP is a little safer. So we were using CPAP. And then we had a 10-bed ICU with patients on CPAP ventilators that wasn't a negative pressure tent. And so these patients were coming from the Mount Sinai Health System, essentially from just overwhelmed floors, units, EDs, So, you know, at the beginning of this, when the system was really overwhelmed, we'd have patients coming to us that have been sitting in an ER hallway for 3 or 4 days. I took report on a patient one day from a nurse who had 17 patients. So one nurse, you know, where I think about normal nursing ratios are like 1 to 4, 1 to 5, maybe 1 to 6. She had 17 patients. So the system, if anybody asks you, is it really that bad? Yes, it was really that bad. The system was really that overwhelmed. And then additionally, I was in charge of an 18-bed unit called a recovery phase unit that was actually built inside the Mount Sinai hospital lobby. And that was for like recovering patients that were just on small amounts of oxygen and nearing discharge. So in that picture that you see right now, so there's the hospital, the tent hospital, and then directly behind us, those other buildings that you see are Mount Sinai. So we were working really close in partnership with them. Just to give you a little bit better feel for what the hospital was like, I'm going to go actually back to that first picture. So you see all the tents there. So in the background, the 3 kind of main tents you see in the background, so that's a ward tent, the step down, and the ICU tent. And then across the walkway, we have an x-ray tent, a lab tent. So we were able to do like basic labs and iStats there as well, and 2 more ward tents. And the back left is the morgue tent. So I mean, really set up a whole hospital system there, which is what we typically do. We just typically do it in another country and somewhere much more isolated than New York. Again, just to kind of share a little bit about that experience and what that was like, just kind of more of the stories. I think, you know, pictures really help tell a story, but in the top right hand picture, that's actually me working inside the ICU. I was actually working in the administrative side as one of the medical directors. So one of the really hard parts about this deployment for me is I wanted to be inside with the patients, but typically I wasn't. Doing a disaster deployment in the US comes with a lot of extra red tape and hurdles and things like an electronic medical system that just require really a lot of administrative work. And so one of the big things, I was helping the providers with documentation and electronic medical records and all of those things. But if any of you have that ER bug, you can imagine, it's really hard to stand outside, not in PPE, while people are getting intubated or coding or just needing critical medical care, because what we do is we all rush to the bedside. So that was a really interesting aspect of this deployment for me, was just not being able to be with people. But I really loved, and when I did get to go inside, you know, much like Ebola, the really hard thing about COVID is that people are separated from their friends and family. People are completely isolated and alone. If they're dying alone, and their families can't be there. And that's really, really hard, right? And one of the things that I think we didn't really expect about this is, you know, we have these open ward tents, which when you're in Africa is cool. But when you're in the US, you can imagine that patients might not like the idea of getting transferred from a hospital to a tent hospital, right? And so we anticipated that people were going to kind of be unhappy when they got there, which was sometimes true. But what happened very, very quickly, no one stayed unhappy because the nurses and the doctors were so kind, compassionate, loving, and attentive. And also, what I think none of us really anticipated was it provided this sense of community. So think about being sick and being in an open ward with 13 or 14 other patients and the lack of privacy. It seems like you would really hate that. But as it turned out, people, I think, really liked that because they were completely separated from all their friends and family, but now they had this whole community of people that were going through the same thing they were, and you were there together. And we actually had a lot of people that would tell us when they were better that they didn't want to leave because they felt such a sense of family and such a sense of safety being there. And so it's just really, really interesting dynamic, was just that sense of community that patients felt. But for me, it was really a privilege when I got to go inside the unit, put on the PPE and all of that, was because I wasn't necessarily responsible for individual patients. I got to just kind of go around and just be with patients, see how they were doing and pray with them, and just offer them a few minutes of support, or be with a dying patient. And one of the cool things that we were able to do, there's a lot of things being a tent hospital that we couldn't offer people that you might be able to offer in a normal hospital room. But we were able to really focus on loving patients and their families. So we had a team that was, their whole job really was calling patients' families every day. A lot of people were getting transferred around in the system, and their families had no idea where they were. So we would have panicked family members calling because they'd been calling hospitals for hours or days trying to find their family members. And so we just started calling every patient. We would call and update their families every day. And then additionally, if a patient was actively dying, we would bring in a couple family members and, monitor them, dress them in PPE, stay with them, and let them see and say goodbye to their loved ones, which is obviously a really special privilege to be able to be with people in that suffering and to be able to offer them that opportunity to say goodbye. Or for those whose loved ones couldn't come, maybe they were someone who was very vulnerable to COVID or transportation or whatever, couldn't come, just to be present and be there for that person as they were passing, I think is a really rare and unique privilege. And then on the left-hand side, on a much happier note, is our last patient leaving. So don't worry, not violating any privacy. He gave us permission. These are published pictures of him. But he was with us for about 3 weeks. He was an older man, had all the risk factors to not do well, but he survived, and it was really exciting to see him going home. He was our very last patient. So every time a patient would get discharged home, we would walk them out, and everybody would kind of gather around the walkway, clap, cheer, and we had a cowbell for the patient to ring that they were healed and going home. So that was always a super exciting moment. So for our last patient, everyone gathered around the compound and cheered and rang the bells, and he got to wave goodbye, and it was a really, really super exciting moment just to see the hospital cleared out and to not be needed anymore because the case numbers were dropping. All right, so I was going to touch really, really quickly on some of my other mission work, and then I'll give you guys an opportunity to ask questions. I know we're running out of time here. So I spend a lot of time in India as well. I'm doing short-term mission trips through my church. If I can get through these pictures. As I shared earlier, India has very, very little access to healthcare, almost no doctors, medical workers. Additionally, some really tough things about India. So if you're familiar at all with the caste system, Dalits are at the bottom of that caste system, and underneath them are called OBCs, or other backward castes, essentially people that are considered less than human. So that's over 750 million people fall into those two categories. 70% of people in India live below the poverty line. There's 150 million children that are in child labor, 1.2 of them in prostitution. Just really rough health statistics. Only 36% of people in India have improved sanitation facilities. So that means like a hygienic place to go to the bathroom, essentially. All right, so some things that I've done in India, just to kind of give you guys, just some ideas of what's out there and what, you can get involved in, and how to do short-term missions in a way that's not just a pop-up medical clinic that really doesn't offer much good beyond the 2 days you're there. So I've started a community health education kind of talk program, do blood pressure, blood sugar screenings. The reason for that is because it gets people to come because they want to get their blood pressure and blood sugar checked. And then it's also an opportunity to refer them back to the local health system and encourage them to use their local health system. One of the things that short-term mission trips can be really bad about doing is creating a sense of dependence on the short-term partner that shows up, instead of utilizing their local health system. And so it's really important anytime you do short-term mission work to encourage people to use their local health system and not break that trust or not break that, that option and not hurt that relationship in the community. So teach them basic infection control and hygiene, basically germ theory, because they're not educated on this stuff. They don't know why they need to wash their hands. They don't know that sickness spreads from one person to the other. Teach them how to keep their kids hydrated when they get diarrheal illnesses, because that's a huge cause of death in children under 5, and some healthy eating habits. So just really basic stuff that it's really easy to teach that, a student can do. So you don't have to have a lot of qualifications to be able to go do this kind of stuff. In the last 2 years, started a mother-child health and nutrition clinic. So essentially getting to know India, I found out around 30% of children are malnourished, 14% are severely malnourished, which is really, really high. There's very few countries that have that rate of malnutrition. And so in that clinic, we screen all the kids, check all their growth charts, screen them for malnutrition. And there's actually been some research done in that area of the country that shows that if you educate the mothers, the rate of malnutrition will significantly change. And so we can go in, educate the mothers, provide the refeeding formula called Plumpy Nut for the kids that are malnourished. And I have contacts, like we're working there with a local church. There's nurses within that church that follow up on these kids. And so kind of keep that program going after we're gone. And then the final thing I do in India is a menstrual hygiene management program. And so essentially women all over the world, right, they have no way to properly deal with their menstruation. They don't know how. They have no education. They're taught that it's shameful. They miss school. They miss work. It's a huge problem worldwide. Really super simple project. Ladies at my church sew cloth reusable pads. We go in, we teach the women how to use them. We take material, teach them how to sew them, take it into the churches, and then those church ladies have a community project that they can do with their neighbors to teach other women this education and teach them how to sew the pads. Other country that I'm heavily involved in is Liberia. This is also a partnership with my church. So Liberia, as you guys probably know, was part of the West Africa outbreak. Before that, Liberia was engaged in civil war for a really long time. So between these two things, their healthcare infrastructure was really decimated. Did some medical clinics there. So remote island we went to, and it had several small villages. So these people, to get to any kind of healthcare, have to walk 45 minutes to a clinic. And that's not really a clinic. It's more like a pharmacy with someone with really no medical training telling them what drugs to buy. So not really access to healthcare, real healthcare, very easily at all. There was a lot of malaria, dysentery in the village that we ran into. So we provided prenatal vitamins for the women, vitamins for the children, treated all the kids for parasites, and as well as just kind of acute illnesses. So this is what it might look like to get to your clinic if you go somewhere like Liberia. So it was a 2-hour Jeep ride on dirt roads with everything loaded up, as you can see there. Then in the bottom right-hand corner, we had to hike about an hour through the jungle, carrying everything. You can see that awesome bridge we got to cross right there. And then finally load everything up in a canoe and cross the river. And then we got to our village. So just some of the things we saw. That bottom right-hand picture, this is the second time I went to Liberia. We were close to the Guinea border. Those people, there were 28 people in that truck that drove 5 hours to get to our clinic. That just kind of shows how desperate people are to get that medical care. In the bottom left there, that little kid, anybody want to guess how old that child is? Just throw something out there.
2 years old.
6. So that was a 6-year-old kid with malaria, severely malnourished, obviously. So just really heartbreaking things that you're going to see that really demonstrate the need. And then the foot, the gross foot, So this lady had an ulcer. When she came to us the first day of clinic, her whole foot, whole leg, swollen, red, fever, really sick. I cleaned out the wound, packed it, gave her antibiotics, brought her back every day of the clinic, continued to clean it out. She essentially told us that it was the first time she'd slept in weeks because it hurt so bad. And then by day 3, she was really getting a lot better. And she told us that she had never believed in God, but because of what we had done for her, she knew that Jesus loved her, and she wanted to start coming to church and be a believer in Jesus. And it's just such a cool example about how caring for people physically demonstrates to them that the love of Jesus is real, and helps them to see who God is and how he cares for them. My next project that I'm working on starting in Liberia is teaching Helping Babies Breathe. If you've never heard of it, you should look it up. You should take the class. It's a really easy, 2-day class. And it's designed for neonatal resuscitation in developing countries. It's very basic. It's for midwives, community healthcare workers. So it can reduce neonatal mortality by up to 47% and stillbirths by 24%, just with these really, really basic, easy resuscitation techniques. So we're going to be teaching that to village midwives in Liberia. So I know I've taken way too long, and you guys are supposed to be done at what, 1, Stan? Okay, so
Yes, yeah.
Really quickly, I'll run through just what I want to encourage you guys with. So merging your faith in your career and what that can look like, because I think it took me, I went into healthcare to do mission work. That's why I wanted to be a PA. And it still took me a long time to figure this out and what this looks like. And so I just want to encourage you guys that there's so many ways that being a healthcare professional opens you up to sharing Jesus, both in your everyday lives and around the world. And so just take 2 seconds and think about, why did you go into medicine? Right? And for most of us, there's some answer there as to wanting to help people, wanting to serve people, wanting to have a career that is maybe both, successful, but also worthwhile, purposeful. There's some aspect there of we wanted to do good for others. But the hard reality that you're going to figure out really quickly when you get out there is it doesn't always feel that way. Medicine can be really frustrating. You can often feel like you're not helping people, right? Especially in the current American healthcare system. You spend more time in a computer than you do with your patients. It's really hard sometimes to be able to address the needs that your patients actually have. And what you realize really quickly is a lot of the problems you're going to face, the problems that your patients are having, can't actually be solved with medical intervention or medical education. Right, that so many times their problems go so far beyond medicine. And that's where that quote from Kent, coming in about medicine allows us to enter into people's suffering, but that goes a lot deeper than offering them medical care. And so what I want to encourage you guys is to think about, when I come to these situations, how do I offer my patients something beyond medicine? And that answer is really that compassion and ultimately the love of Christ. Healthcare really opens this door, just like that lady I shared about in Liberia, that she never believed that God was real or that he loved her until we showed up and physically showed her that God loved her, right? And healthcare allows us into people's lives, into their vulnerable places where no one else can go, right? Very literally, right? So Ebola, you can't touch someone with Ebola without getting Ebola and dying, unless you're a properly trained healthcare worker, right? You can't take care of someone with COVID without getting COVID, unless you're a properly trained healthcare worker. And so people that are isolated from everyone else, we have the opportunity to go take care of. But that also goes to, how about that drug addict in the ER that no one cares about, no one's gonna bother to take care of, and they've showed up in your ER overdosed for the 5th time this week, right? How are you gonna respond to that person? And I can tell you personally, it's very easy to respond to them in the incorrect way. But we have this open door to be there for people in places that no one else can or no one else will. And so it really offers us this unique opportunity. And what God has just really convicted me of over the last 10 years of my career as a PA is that we have this privilege to walk in Jesus' footsteps in a way that no one else does. And because if you think about Jesus' ministry here on earth, what did he do? He did two things, right? He taught and he healed. I mean, over and over again, look at what Jesus went out and did. He was teaching and he was healing most of the time. And we get to do those two things. We're trained to be healers, and we can choose to be teachers, and we can choose to be bearers of the good news of Jesus Christ to our patients and to those around us through healthcare. I mean, just a few verses here. This is a very few, but look at Matthew 4:23. Jesus went throughout Galilee, teaching in their synagogues, proclaiming the good news of the kingdom, and healing every disease and sickness. Matthew 14:14. Jesus went out and he saw the great multitude. He was moved with compassion for them and healed their sick. Luke 4:40, which is one of my favorites. When the sun was setting, all those that had any that were sick with various diseases brought them to him, and he laid his hands on every one of them and healed them. So here he was at the end of the day. He'd been teaching all day, and every person that was sick in the village came to him, and he didn't just quickly heal them. He, with compassion, touched and healed every one of them individually and with love. And we have this very, very unique opportunity as medical professionals to follow that example and to go out to people in their vulnerable places and love them individually. So if that's something you're interested in doing, right, and I hope that it is, I want to encourage you that I know a lot of you are still in school, still building your careers, all of those things, but how do you prepare to do that? And the answer is that you need to start now. A lot of people want to show up and do a disaster response or go on a mission trip, and they don't have the skills or the experience to actually be useful doing that. And so if it's something you're interested in, you need to build your skills, your knowledge, and your experience to be prepared to do that well. Do an international rotation while you're in school or while you're in residency. Take a class in infectious disease, do travel or wilderness medicine. There's conferences for those things. There's lots of, special courses for those things. Do volunteer experiences that get you good experience. Go on an international mission trip over your break or whatever that looks like. But do those things to learn. And it even comes down to simple things like work on your physical exam skills, right? Because guess what? When you're working in an Ebola center in the Congo, you don't have x-ray machines, CTs, and labs, right? You have to do a really good physical exam and figure things out. You have to have a good knowledge base, when you're doing a mission clinic in Liberia or India. So work on those skills. Don't just rely on diagnostic tests that you might not have access to. Secondly, build resilience. So these are hard situations, right? These are stressful situations. They're physically, mentally, emotionally, all of those things. They're going to put you under stress, and the worst of you will come out. And so you have to be prepared ahead of time to build that resilience, to deal with difficulty, to deal with stress, to deal with lack of sleep, to deal with suffering. Now, being in medical school or PA school or residency, it prepares us for a lot of these things because we kind of have to figure out how to deal with those situations, right? But we need to build that resilience into our lives if we're going to be able to do this kind of work. Number one, be in the Word, be in the Bible, develop a daily discipline of quiet time, because the number one thing you need to do this work is Jesus. So build him strongly into your life. Build community, have a community of friends that you can go to and talk to, that support you, that encourage you. Deal with your struggles and your weaknesses, because they're only going to be highlighted when you're overseas in a stressful situation. And develop a theology of suffering. And that's a really important one. We need to understand God's viewpoint of suffering, what the Bible says about suffering, and how we're going to internally deal with seeing the hardest things that are happening in the world. Build faith. So this one, don't wait till you're on a mission trip. Don't wait till you get that job. Don't wait till you get that deployment. And expect that you're all of a sudden going to be good at sharing your faith, or good at doing mission work, or good at, whatever. Do that now. Be Jesus' hands and feet where you are now. Share the gospel with those around you now. Find where Jesus is working, where he's placed you. I think that's something that took me a long time. Somehow it's like I went to the ER each day and I forgot that Jesus was there just as much as he was on my mission trip in India. How can you be there for your patients now? And so how can you witness to those around you and share Jesus with them now? Don't wait. And then finally, just some practical next steps to think about if you want to go into this kind of work or have opportunities to do this kind of thing. Look for a mission trip. Christian Medical and Dental Association has a ton of mission trips that are great for students. Doing it, like I said before, do an international rotation, take a class related to global health, volunteer at a community clinic. There's free clinics. There's all kinds of low income clinics. Go work at one, get that experience. There's residency experiences that are focused on underserved populations, or with actually there's some Christian community clinic associations that have family medicine residencies. Go to a medical missions conference, find a church that's missions minded, and we'll build those opportunities and experiences for you. Do books, Bible studies on missions and the gospel, and having courage and boldness. And then finally, I just want to encourage you to choose faith over fear, right? Whether that's fear of money issues, or fear of not building your career, or fear of being exposed to COVID or Ebola, fear of going to a place in the world that's unstable. Choose that boldness and trust in God. We feel in control when we're here in our normal situations, but we're not any more in control here than we are there. And so just trust that God will take care of you. And I promise you, the sacrifices, financially, time, safety, all of that, it's 100% worth the joy and the peace that comes from knowing you're doing what God designed you to do. And all of you, you've gone into a healthcare field because God has called you to that. And so utilize that, leverage that to be Jesus' hands and feet and share his love with others. And I will skip my last slide there. Well, thank you guys so much. I know I'm over time here, so if you need to go, please do so. If anybody wants to stay on and ask questions, I'm happy to do that as well.
Hey, thank you so much, Shannon. We really appreciate you spending time with us today. Such great information. Oh my gosh, I'm just so beaming with pride. So proud of just seeing her from being a student there, a PA student in Houston, and now just to see how God has used you in such a mighty way. It's just such a testimony of his faithfulness, and yeah, it's just been wow. Well, I'm speechless. So it like she said, we are out of time, but if you guys have questions, go ahead and ask them now. I know Carson has a great question to ask, and not to put him on the spot, but yeah.
Hi, thanks, Shannon. I think you kind of already answered the question that I was going to ask, but I'm a radiology resident, and I was curious to know what the role of radiology is in these situations, and I'm sure it varies depending on site and location. And then I guess along with that, and this expands to beyond radiology, but what's the role of telehealth? And as healthcare is changing, and here in America, I think towards more of a telehealth type system and utilizing that, do you foresee that there could be some more opportunities for global missions, through our telemissions, I guess?
Yeah.
To know your thoughts.
Good question. Interesting questions. So I think the answer to those two questions might actually go together, being that I think not having a radiologist available is a common issue in missions work and overseas work, or I spent a couple of weeks at a rural hospital in Thailand last year, and we certainly did not have a radiologist reading our films. And so I think that is certainly something that is a huge need. And while it's not something I've seen a lot as radiologists being a part of missions, that might be more of an issue of radiologists who are willing to do that versus opportunities where it would be useful. So I think very similarly, as a PA, a lot of times I have to kind of create my own opportunities because it's not common for PAs to be doing certain things. I think that if you seek out those opportunities and ways to make yourself useful, they will absolutely avail themselves. And telehealth would be an amazing way to do that. You don't see much telehealth, or I haven't personally, in mission work. But I hope it's a door that will continue to open, because it's certainly a great way to provide specialty consultations or, any of those things. I think you will see more of that as technology reaches corners of the world. And that would be a great way to make services like a radiologist available. So I think that, yes, it certainly should move that way, and I hope that it will. But I think one of the really simple ways that you can kind of avail yourself is for instance, even when we were here in New York at the tent hospital, where we were in partnership with Mount Sinai and had their specialists available to us, it wasn't always easy to get those consultations like formally happening. And so like some of the ER docs would send pictures of radiology films to their friends or their cardiothoracic surgeon buddy, and so just make friends and let people know that like you're willing. Like if I had a radiology buddy that I could send an image back to, yeah, that'd be great.
Well, thank you.
You can send me your images.
Awesome.
Carson lives with us, so yeah.
That's cool. That's a good question.
Yeah. Well, hey, I just want to quickly make a plug for Christian Healthcare Service Corps. If you guys look at your chat, there's an web address to healthservicecorps.org/training. And what Shannon was just talking about, they have some of the best training there, and some of our students have actually participated in that, in some suture training and ultrasound training. So yeah, I can't stress enough just being plugged in that way and trying to get your experience now if you're very interested in medical missions. So thank you again. I'm just going to close us in prayer. Okay. Let's pray. Dear Heavenly Father, God, we thank you so much for today. We thank you for each and every one that was able to attend, and just wow, just so thankful for Shannon and how you've used her. And Lord, I just pray that you will continue to make her your instrument, Lord, and your instrument of peace. And Lord, that you would use her to reach the uttermost parts of the world, Father. Lord, we thank you again for Shannon, for her sharing her experiences with us, God. Lord, we thank you. We pray all these things in Jesus' most precious name. Amen.